retrorenal colon, it's rarely rare the presentation, but if you encounter or if you get it in the patient, real patients, it may complicate your PCNL outcome or a PCNL surgery. So you should know how to do it safely. And you all know it's common in left side, upper pole puncture. It's common in prone position. It's prone position compared to the supine positions. And it's common in thin patients because bowels, kidneys are crowded. So you all know the colonic colon positions posterior to the kidney. It's a little bit rare, maybe around 10% of population have this anatomical variation. So what we all wanted is the CT evaluation. So we should have the clear idea about the colonic anatomy, kidney position, our point of entry before we before we decided for the PCNL. So you can avoid it. You can avoid it. So if you carefully study the CT scan, or if you choose the posterior calyceal punctures, or if you go subcostal access whenever possible. And best thing is the ultrasound guided puncture if it is available. So here I'm going to present my original case. It's a 23-year-old boy presented with a left side PUJ 3 centimeter stone. So here are the CT views. So you can see that. So I'll give the axial views of my patients, the CT. So you can clearly see the colon is just going posterior to the kidney. And there's a large PUJ stone also. The colonic shadow is overlying the posterior lower pole of the kidney. So we should have a good plan of this the patient's anatomy. So what we did was, we don't have ultrasound access in the theaters. So we just went through the help of fluoroscopy. We marked it. We select the point of entry. So it's a lower pole is covered with the bowel. So I can just choose the mid pole and the upper pole. So I just went up. That's a subcostal axis. Subcostal axis. So it's give more safety. So you can see the axis here. I just went through the close to the subcostal line. This is my initial puncture. There are other techniques also. The people use ultrasound guided puncture ultrasound guide puncture is the best one. Some people go more posterior to the posterior line and come from posterior to anterior. Yeah, that is also gives some good outcome. So once you go in, then you should know whether you have damage gone through the bowel. You can X-ray, you can see it. If the bowel shadow move with your puncture, then you have doubt on that. So if it is not there, then you can safely puncture, safely dilate, safely. So your surgery will be safe. So you can see now the X-rays, you can see there are two stones. One is in the PUJ and another one is in the lower pole. So I have no option. I have to choose lower pole. So my puncture, I just decided subcostal, but a little bit oblique or parallel to the mid-calyces through the lower pole. So we achieved, there is no colonic shadow movements, dilated, and we went in. So this again, I'm just pass the guide wire through that. So you can see the the landmarks again to the guide wire. So it's subcostal, iliac crest, and I went above the posterior line. Right. So I have gone inside. The rest of the steps are similar to your standard supine PCNL, laser fragmentation, and removal of the stones. So when you come out from the track, you can give a final inspection whether you have gone through the bowel. Most of the time, no. So if you choose the access, the entry point correctly, take time, give time, analyze well your CT, get us access. Thank you.